and great pleasure to be here. And the last session, so I'm sure we don't take time. I think once I did Viraj a favor. I called Viraj in a surgical meeting, and he felt really odd, and he repaid the debt back. So, and got to see some of our fellows, Divakar and Praveen here. Where is Praveen? Can't see Praveen. Praveen, you have to sit there where I can see you. Okay. So I think we're going to talk about rectal cancer, and I think about the last 2 years with all this TNT trials coming on, nothing is wrong, everything is right. So you see how things go. So when you're going to talk about rectal cancer, idea was to save lives was putting good surgery. Of course, you could do that, and you had to do sphincter preservation, you had to look at quality of life and urinary and sexual function. Then when everything became better, local recurrence went down, then people started thinking about LARS, and what's happened over the last few years is organ preservation. So once a patient comes to you now, so Praveen, if you think someone has referred you a patient with rectal cancer, what's your first intention of treatment? Do you have any plans, or how do you normally think? Because now I think, what would be the plan, would I say? What do you think?
So the first step would be to stage the disease and get a diagnosis, and then based on the stage, obviously we'll be trying to do the right kind of treatment. So if I tell you
it's just a locally advanced rectal cancer,
yeah,
it's curative, and
so
then if you see someone, then how are you going to proceed? Because
yeah,
now everything is changing. So yeah.
So locally advanced rectal cancer, again we can further stratify as to whether it is a really bad biology disease or a good biology disease, and based on that we can decide on the neoadjuvant treatment, like something like a T4 and a MRF positive disease, anteriorly based tumor, high nodal burden and low rectal tumors. Definitely a TNT is on the cards, and if it is an upper rectum, again it's a plus minus based on the tumor burden. Mid rectum, yeah, most of the times decision for some neoadjuvant treatment, but may or may not be a TNT. So that's how I think. And we also have to fit into the whole scenario the possibility of sphincter preservation, and at the same time we also have to consider the tolerability of considering a TNT, especially in older patients, whether they'll be able to tolerate the entire course of chemotherapy, and at the same time we also have to consider what is the impact of a stoma on that quality of life, whether they'll be able to manage or not. So these are certain things which will be running in my mind.
Pandey?
I agree with Dr. Praveen sir, actually. So now not only survival, I think the functional outcome, quality of life, as well as the options, the treatment option, the toxicity that the patient accepts, I think that takes a patient precedence compared to what we used to do a couple of years back.
Good. So let's ask the radiation oncologist. See, if a patient comes to you with rectal cancer and he's been referred to you first, what is the first thing?
Sir, yeah, so I agree with what Dr. Praveen and my other surgeon friend tell. In addition, yeah, I also try for organ preservation. Being a radiation oncologist, probably this is the biggest burden on me, to try to preserve, especially in lower third disease.
Viraj, if it comes to you, so we have everything, surgeons, radiation oncologists, or medical oncologists. So everyone will have a different idea. So Viraj, if a patient comes to you with locally advanced rectal cancer, what is your first thing that comes to your mind?
The first step I do is MSI test.
Sorry, what's that?
MMR testing.
Great, fantastic.
That's the first test. And that's the message we want to send. First test, any rectal cancer, that's the test. Assuming MMR is proficient, then I completely agree with him. We are still in the era where survival is more important than the quality of life. That is at least my philosophy. If it means stoma, it means stoma, but survival is first.
So I think everyone is thinking differently. Surgeons are thinking of sphincter preservation, radiation oncology is thinking of organ preservation, and Viraj is thinking of survival. So everyone may start with the same thing. But I think what patient, if he comes to me, I normally think if it's low rectal cancer, would he be a candidate for organ preservation? And then you would use your resources. Do you need radiation, or do you use medical oncology, things like that? So important things. So first, if the patient is not for organ preservation, then you look at other things as well. So suppose if a 56-year-old female comes to be bleeding PR, growth is 2 to 3 centimeters from the anal verge, looks higher rectal cancer, T4, and maybe call it N2 or something. So Viraj, what would you do? What would you suggest for this patient? Okay, Divakar, yeah. Sure.
So she's a young patient, sir, and it's a low.
I'm very happy to hear that. 54.
Yeah. So 54 is, I think, young only.
Good.
So, and it's a low rectal cancer. It has high risk features of infiltration of uterus, and of course, organ preservation is one thing that we should think about. So, my approach here will be probably to subject her to TNT. If you specifically ask which approach of TNT, probably it's consolidation first, radiation first, followed by consolidation chemotherapy. That will give her maximum chance of probably the clinical and PAT-CR. And then if she fits into wait and watch, if she accepts, then probably that is the one option that I'm going to give to her. And if she doesn't, then maybe.
And for surgery. Okay, Praveen, do you differ?
Looks like a bad burden, a disease burden, touching both the levators and quite low. The tumor's bulk is also pretty high. So I would go for TNT, but probably a short course RT with the completion of chemo rather than going for long course.
Okay, so you're thinking of Rapido and you're thinking of opera. Radiation oncologist, was you've not answered for this.
So yes, sir, but I somehow would prefer long course, not short course. This is a T4, bad T4, and recently we have seen.
You're my man.
Yeah.
The only problem is that because it is lot of high risk features are here, so she'll be having distant failures, more probability of distant failure. So wouldn't it chemotherapy or maybe short course followed by chemotherapy?
Okay, boss, have you got any other preference for this?
So I have slightly different opinion. If it is above the internal iliac level of lymph node, I would rather go for the chemotherapy first, followed by long course or short course, depending on how it has responded to the disease, and then go for surgery if sphincter preservation or organ preservation is not possible. If she falls into the wait and watch category, I'll prefer TNT.
You are a radiation oncologist.
Yes.
Oh, very good. I'm so happy to hear that. Viraj, it must be working with you.
So, so yes, TNT, but like I agree, these bad ones, the last 4 ones that you mentioned, we typically do Prodit style TNT.
Right.
We start with chemo, then add RT. Vis-a-vis, if no bad ones, we start with RT, then chemo.
So I think we have lots of trials which are there actually. So we have Rapido, which was the short course, then you have Prodigy, what is there, and the Opera as well. All these trials actually increase the pathological completers from some 13 to 28%. But the organ preservation trial, the only which is there is probably the Opera itself. So I think for the low rectal cancer, but this is the high risk patient. So in this high risk patient group, so what happens is you will have a response rate of 18% or so, but local regrowth is going to be high, 30% or so. So I would think not of organ preservation, like Viraj said, you would think of probably try to give some sort of neoadjuvant therapy, either Prodigy or consolidation, whatever. So what do you think of all the TNT trials? You know, it looks like pathological complete response is high, DFS improves, metastatic free rate, but overall survival only improved in Prodigy 23. And why do you think, Viraj? And would you concentrate on overall survival, or are you happy with just
Even
surrogate
DFS
endpoints of DFS?
In colorectal cancer, DFS is a reasonable endpoint. We don't shoot for OS for any colorectal disease. A DFS advantage was seen in both TNT studies. So I think so that strategy is proven. Which one depends on, if it's systemic failure more likely, you start with Prodige. If it's local problem main, you start with Opera. Like we don't use Rapido in our clinic. We use more Opera.
So if you were going to have, so all the other trials used K-POX, a double treatment, and they didn't improve overall survival. In fact, Rapido improved metastatic free survival rate, but the local recurrence were higher and overall survivals there. So that's why probably Stella didn't show any improvement in either DFS either. So that is there. So if you were going to think this is a high risk patient, and you think there's a high chance of metastasis, and you wanted to improve the survival, would you use a triplet like Prodigy, or would you be happy with normal chemo doublet?
Good question. We don't have answer that what is the irinotecan doing here. We have done FOLFOX plus followed by RT also, not strictly following Prodige, because FOLFIRINOX is a hard chemo, and 70, 75-year-old, and we have these patients coming to our office, bad tumors, 72 years old. FOLFIRINOX may be little too much for them to take. So we have done FOLFOX and we've got the results. So, and there is no trial of FOLFIRINOX versus FOLFOX in rectal cancer in neoadjuvant setting?
Okay, it's coming. So you asked for it, so it is there. So you have the Janus trial. He's from MSKCC. He's been appointed as head of surgical oncology in MD Anderson, replacing George Jang or something. So Janus trial is there, which is trying to compare doublet versus triplet. This is with long course chemoradiation, and then you have the ensemble trial, the same thing with short course and thing. So that will actually show whether triplet is making the difference or TNT. Otherwise, you always think TNT for everyone, but not really. But like what you said, you have to look at the patient as well. So suppose elderly patient, not really, young patient, a musician, would you want to give oxaliplatin toxicity? Okay, let me go back. So do you want to give TNT to everyone, or would you give it very selectively? Divakar?
So it will be selective, sir. It will be selective, especially with the prospect now. If the patient is very young and if the upper mid rectum T3.
For these low rectal cancers.
So for here, I think TNT will for everyone actually, sir. In such patients, I think TNT should be given for everyone.
Right. Okay. But sometimes I always used to think normally you give chemoradiation and you see them at 6 weeks and you will have a complete response at 15%. Okay. And if they've not responded or near complete, then you give chemo later and then you can avoid. And the role of adjuvant is not proven itself. So this step at 6 weeks you have a look at it and it's a complete response clinically. So there is endoscopically is okay, and MRI also doesn't show anything else. So Praveen, would you want to do anything else for this one? So she looks pretty good, and yeah.
So if the plan was TNT, ideally we'll complete the complete treatment and then probably reconsider whether we want to operate her or put her on wait and watch. But
so this
I
lady
won't
has
stop.
only received chemoradiation, now it's a clinically complete response.
Yeah. So at this point of time, it looks like a clinically complete response. We just have to discuss, because the plan was to do a TNT, and we have done only the chemoradiation part. And whether, if at all we stop chemotherapy now, there is no evidence that whether how they are going to fare compared to if they complete the TNT.
Yeah, means
so
if they
I
got
would prefer to complete the chemotherapy.
Yeah, there's the trial in Brazil looking at if you already got complete response, if you give chemotherapy, but it will require local regrowth road. Complete response now, do you want to give brachy boost or something? You're a radiation oncologist, you bought a device to CR.
Personally, I have never done it, so I'm not sure. Probably we have sent in fact a couple of patients to Tata, but these were not this kind of patient.
So wait and watch is quite an accepted standard of care for all of you.
Yes.
Devakar, if someone comes to you with wait and watch, how would you counsel them?
So I'll first tell him, sir, that wait and watch is not deferring surgery, it's delaying surgery. They might have local recurrence as well as distant failures. There's close to 25 to 30% risk of local failure and 10 to 15% risk of distant failure in due course of time. It has to be very structured follow-up, like 3-monthly MRI, a sigmoidoscopy, clinical examination at least by 2 consultants, so that they are in coherence. And it has to be strict follow-up, so that if at all it comes back, we should intervene as and when required.
So informed patient, and you do the counseling, and if it's okay, 20% local regrowth is okay, and larger the tumor, the greater the chance, 10% distant metastasis on follow-up. And compared to what we think locally advanced, I think if you have early tumor, I think that is changing. It will have less chances of local regrowth and complete response or more. So if this for the metastatic patient Viraj, with liver mets, and you given this and the liver mets have disappeared or they're still there, and the primary has got complete response. When you got a persistent liver lesion and the rectum has clinically complete response, so would you refer this patient to a surgeon for extraction of the primary and the liver, or
Certainly liver first.
and would you like to observe? Praveen, what would you do?
It is complete response at both sides.
No, primary liver lesion is still there, or it was liver lesion was there and then no whatever thing. But I think I tell you the liver lesion is there. So now what do you do for the primary?
So primary, I would still prefer to operate both the liver as well as the rectal side, probably in the staged manner.
Divakar?
I will differ, sir. I think I'll only take the liver out and keep the primary in waiting protocol.
Radiation oncologist, but you are not speaking anything. Come on, the idea is to encourage you to talk. So
I would ideally offer this patient liver radiosurgery SBRT for the liver lesion. Check with the immune status again, and if patient falls under the
And these are all old patients, so we are not done MSI. Now MSI is standard of care with biopsy.
Yes.
All
So-
patients have it, so that's why they received only
Yeah,
this.
so if MSI is high, this patient does not go for liver surgery at all, go for radiation. It has excellent response in combination with immunotherapy. If patient wants to wait and watch, if that was the primary goal, even with the metastatic disease, why operate one place and not the other? We'll go for non-invasive treatment.
So
for the
again, the data for local regrowth is normally 20%, but if you have metastatic disease, there's the data from the pooled registry that local regrowth rate is 40%. So you can do whatever, but you have to inform the patient. This is the thing. So patient comes back 1 in 40% times with local regrowth, so you know you have already informed them. So whatever the patient wishes, so patient is sent. Okay. Let's look at this 33-year-old male, mucinous adenocarcinoma referred from outside. This was the biopsy from there. We did a biopsy here with came as villous adenoma with high-grade dysplasia. Colonoscopy is complete. It is proficient MMR. Baseline MRI looks like T2, N0, N1. Someone has outside has already given 4 cycles of Capox. Okay, Praveen, patient comes to you. What do you want to do? 4 cycles chemo he's already received. It's okay.
High burden disease. So I'll give radiation before operating.
Okay, okay, Divakar.
Same, agreed, sir. We get radiation.
Okay, anyone? Radiation oncologist. Looks like a mucinous tumor. Do you think after giving radiation it's gonna change, or by giving chemo it's gonna change?
Looks like very high burden with the mucinous histopath. We are not very confident how it is going to respond to radiation in combination with capecitabine.
So now, if you look at it, suppose now don't look at this tumor itself. You've already received neoadjuvant therapy. So you got MRF-free disease, N0, N1. We know MRI is not very good for nodal disease itself. Okay, so and it's not sphincter is preserved anyway. So are you thinking of something else, other trials which are there? Obviously, you have to finish all the trials. What do you think? So let's come to the
It was initially, I think, node positive, sir.
Sorry?
It was initially node positive to begin with.
So if you give chemo radiation, is it going to improve survival? Means I'm not
No.
sure giving chemo radiation over the lifetime has improved survival for anyone.
My idea of giving radiation in this case would be to sterilize the lateral pelvic area, not for the primary.
That's true, but there are no lateral pelvic nodes before, so I don't know whether you do prophylactic. Anyone? Radiation oncologist, what do you think? Would you refer to a surgeon? Viraj?
No, I think so. Long course chemo radiation and then operation.
Okay, so okay, it doesn't look too bad. Looks mucinous, I think. Okay, so we just did a lap low anterior resection for him because we are inspired by the NHPR KMS focal signaturing, margins are free, 1 of 28 nodes positive, MSI stable, and adjuvant chemotherapy is planned. So idea is radiation does not improve survival. Okay, so that's not going to do that. So if you're going to have clear margins, the recurrence rates are low. So now we are thinking of improving survival or organ preservation. This was not a candidate for organ preservation. So now this is a 32-year-old chap. So if you give him chemo radiation, you're looking at all the side effects. He will definitely have a stoma, he will have leaks, he will have LARS, he will have sexual dysfunction. He's going to live to 70 hopefully with good surgery. And you would have ablated gonadal as well. So radiotherapy has problems, and one of the most important problem of LARS is low rectal tumors and this one. So can MRF negative patients undergo upfront surgery? You know, there are quite a few studies. Viraj, you want to talk about it? There was a study in Mercury, which actually from UK itself, if MRF free, they don't give neoadjuvant therapy, and their local recurrence rate 20 years back was 7% or so.
So not for low rectum, but yes, mid and upper rectum for sure. If MRF is not involved, even at our center, we go for operation first approach.
Praveen?
So apart from Mercury, there was, but there are 2 more studies, prospective analysis, but small numbers. So what they had seen, most of the studies have included both mid and upper, lower rectal tumors, more of mid rectal tumors, good biology, T3A, T3Bs, and the important thing in Mercury was regardless of the nodal status, they could achieve the same amount of recurrence rates as well as survival in spite of not giving radiation. So that is a very important point. And the other studies also have reinforced the same thing. So I would actually interpolate these 2 mid-rectal tumors which have got good biology and not really for a low rectal tumor. I'll be more circumspect about low rectal tumors.
So actually, I won't stress all of you. So I think when you're in institute, you have a lot of time on your head, and someone calls you on a weekend for a meeting. The only person who benefits from the meeting is you yourself. Then you read up all these trials. So there are few trials. If you have MRF free, then there are two trials. There are Prospect and Convert. So Prospect is the American trial, 1,000 patients, very low risk patient, MRF free, less than 4 nodes or something, and sphincter not involved. So this was one. Then Convert is a Chinese trial. So once the result of FOVAC comes, it was again MRF free, but they took low rectal cancer, they took high risk patients, EMVI positive, short term results have come out. And FOVAC is a trial which is high risk patients, MRF positive and to EMVI or something, and we'll come to that. Okay. So this is the Prospect trial, 1,000 thing, the low risk patient, MRF is free, sphincter is not going to be involved at less than 3 nodes or something. Groups are quite matched, upper rectal cancer was there. So none of them, progression or chemotherapy was very less, 6.5%, R0 resection was very good. Complete response with neoadjuvant therapy was 21%. So with chemotherapy alone, you can have complete response. So if it's very high risk in FOVAC, it's 6% or so. Low risk, 21%. And if you first convert or something, it's 11% or so. You can have complete response for this. Complications are slightly higher on this side, but it's okay. Most important, 5-year local recurrence rate was very low, 1.8 and 1.6%, and there was no difference in DFS and OS. So chemoradiation is not required in low risk patients which are MRF free. But I agree with Praveen, sometimes it's a very bulky tumor, you would be happy to downstage it, but I think looking at mucinous or villous adenoma, you may not do it. Other thing is the Convert trial, only short term results have come out from China. This looked at higher risk. So even if you have EMVI positive or sphincter was involved, they still did it, and this was 4 cycles of Capox compared to CTRT, and outcomes were still the same. That was the Convert trial there, and the most important trial is the FOVAC, which was average risk patients, and they had 3 arms. One was giving only chemotherapy, the second arm was giving Folfux and only 5FU based therapy, chemo and radiation, and the third arm was chemo radiation thing. And if you look at them, the pathological complete response in chemo is 6.5%. But local recurrence rate in the arm is exactly the same. There is no change in DFS and OS. So giving chemoradiation itself is equivalent to this one based on the trial. So there are almost so many trials now. Most important thing, the results of the FOVAC trial, if you look at it, of those patients who had radiotherapy along with this one, their functional outcomes are very bad. Incontinence is low, pad usage is high. So if it is a young patient and if you think you can confidently remove it, then probably based on this, I would recommend it. You need evidence to do anything. So as long as you have evidence, you have done the right thing. So you have evidence if you have MRS free and leucine. And can we tailor radiation based on that? Suppose if you think, so what I think, if patient is upper or mid rectal cancer, am I going to do organ preservation? I am not going to do. So what can I do now? I have to improve survival. So I can give neoadjuvant chemotherapy and see if it shrinks or not. If it shrinks and MRF is free, I can operate on this based on this trial. If not, then I can act them. So that is called tailored radiation plans. As Professor Denost was here from Bordeaux, and he done the same thing. So this was the GRECA-4 trial, only small numbers. If they had 75, there were 4 arms in this, I won't go into detail. So in the first arm where there was 75% reduction, they operated on this and their outcomes were very good. And based on this, they have again a GRECA-14 trial where they have the chemotherapy first. And if they have 60% reduction, they randomize to either surgery versus CTRT. So results will come out according to them. Okay, I think enough of medical oncology. There are 2 surgeons there. Okay, now second option is for surgery, open lap or robotic. What do you think, Divakar? 63-year-old lady, mobile lesion 2 by centimeter from the anal verge. T3N1 looks good. You given chemo radiation, and patient said she wants surgery. So we will discuss this. So she's got a good response sort of thing. The lesion is still there. MRF is free, 3 centimeter from the anal verge, and you want to do an intersphincteric resection. So what option would you prefer? Open, lap, robotic?
So it's MIS, better robotic. If not, then lap.
Praveen, you have both available. Hospital is going to care you more if you do robotic.
Better robotic.
Good. Any other preference? Just for money, or is it for something else? Come on, man. We are the only surgeon. There are only medical oncologists here. Good to see the smile on your face again, man. I can hear the jingle. Let's, Praveen.
Any minimal access approach. I'd be more comfortable doing laparoscopically. It will save a lot of time. I'll finish it faster.
So lap or robotic, I think open is out. I think blood loss is less. We have shown it. Career use plan for robotic ISR, that was done. So ROLA trial initially didn't show any difference, but it was only advantages for obese patients or low rectal cancers and stuff. But then the real trial has come, which is all positive outcome, short term, long term, any outcomes you think is positive, so you can do it. But so do you think if you do a robotic ISR compared to lap ISR, do you think functional outcomes will be better because you do a lot of dissection from the top end? What do you think? Were you there in this study? Oh, you must have been around.
So in this
So I
one,
think-
actually, there's no difference, but I always felt that robotic may probably thumb will be a little better.
So the real trial, the fun part was the operating time was the same for both the arms, laparoscopic and robotic. They said there is a lot of quality control, but it is, I am not sure whether there were more APRs in the laparoscopic group, and whether they timed the perineal part as well. It is they are not mentioned in the trial. So it is just like whether you want to use a ordinary sedan or a Ferrari to reach your goal. So ultimately the goal should be the
it's a
same.
better thing, and you can definitely good surgery, especially for recurrent cancer, for dissection is really good. But you have to believe the null hypothesis. You use both your arms and see if it's good or not. So in our experience, if we didn't find any difference in terms of loss of external robotic or laparoscopy, if you have the robot, I think we definitely can decrease the perineal dissection. Okay, we have a case for, are we on time? 38-year-old male, 5 centimeter anal verge, looks like a really bad tumor, fixed posteriorly, proficient MMR, CE is 50, it's got everything, EMBI positive, MRS, pre-cycle pressure involved. This is what the tumor looks like, a lot of them in TMH actually. So what would you do? Bad tumor, Viraj?
Chemotherapy, FOLFIRINOX.
Do you want to give them long course chemo, radiation and consolidation?
So,
So the aim is obviously looks like a bad tumor, so someone
Yes,
has
sir.
to operate on these anyway.
So basically, he will need chemo radiation, maybe after neoadjuvant, but he will need, yeah.
Okay, so what do you think, Viraj? He's your radiation oncologist. Chemo first or radiation first?
No, he said chemo first, then
Then
chemo
chemo
RT,
radiation, yes.
and then probably
Yes,
exenteration.
yeah. But probably this was given short course. I would not prefer
I
short
know.
course again.
So sometimes you can have the intermediate one, so you can have
Yes,
short
yes,
course in this
yes,
one.
yeah.
So I think from my personal experience, if you give short course, dissecting in the intersphincteric space is difficult. So, but if I think I'm going to do a APR or something like that, then this is okay. So so FOLFIRINOX was given because the whole idea was you're going to have a metastatic spread. So as surgeons, we are still thinking. I look at all the medical oncologists there, and I am so happy that I'm a surgeon. I don't have to think so much. So FOLFIRINOX is done. So there is a decrease in the bulk of the tumor, but it still looks bad and stuck to the precycle fascia there, and it looks like maybe at the level of S2 it is there. Divakar, I know you've done a lot of sacrectomies, so what would you think? So the problem is somewhere down there. So if you look at the piriformis is there, and near the sciatic notch there, and it's totally stuck at that point. What do you think?
So exenteration with sacrectomy is one option that we can give. At the same time, patient has to be counseled really well about the care that is needed after that. I don't have much of experience, as you said.
No, I know
we have few
you've
numbers.
done more than me.
We have
I think Divakar is from Raipur, Chhattisgarh, and I think he's got a good unit and a good orthopedic surgeon. They've done quite a few.
So we had, total we had 6 till now, sir, and 3 of them recurred actually, distant met failures later. But touchwood, the first one that we did, young girl, and she had defaulted actually after finishing her radiation and chemotherapy, and then she came to us after 2 years with that kind of thing. So we re-challenged her with chemotherapy, and then we did sacrectomy. She is alive, 2.5 years now. So looks like that.
You're looking at a glass half empty. Okay, 50% survived. Okay, if I was a medical oncologist, I would.
The follow-up is less, sir. Follow-up is not much.
Praveen, what
We
do you
need some
think?
more time.
Praveen, yeah, I know conscience is a very important thing. In surgeons, all these patients are going to come back to you. So you may do a lot of radical surgeries in the beginning, but then you taper your crowd down. So Praveen, you think you can do it MIS?
So was there a response actually for the
Not much. It looks the same. It was mucinous sort of thing. Look, precycle fascia is fixed. In these patients, we normally do a staging lab. A lot of them will end up with peritoneal disease. You always keep a standby case, and so you're not very popular in the hospital. A lot of patients starving. What do you think, Praveen?
Yeah, we can try minimal access.
Anyway, I think it's going well. I think we do a lot of cadaveric work as well, so we planned this out. So we managed to do a lap pelvic exentration. It wasn't too bad because you can do everything from the top, and then you can turn it prone into an S2 correctly. And for high risk patients, we can bring a sigmoid out and you join the ureter this, so the conduit problems are also less, and there's hardly any incision there. So it was pretty okay. Margins are pretty free, but hopefully
Standard.
Okay, so we won't go on to that. Next. So I think MIS exentration we've done quite a lot, maybe the largest in the world, more than 220 or so, but you can do something less. So Praveen, if you had someone touching only the seminal vesicle after neoadjuvant radiation, would you do extended resection, bilateral SV or something, or?
Yeah, I would prefer that, sir. Bilateral seminal vesicle excision with prosthetic shave after assessing the imaging. So,
Do you do lap or robotic, Divakar?
So I'll prefer lap, sir, but I will not do prostate shave if it is only touching.
I know. I think if it's involved, then you'll have to do an exentration anyway. I think with robotic lab, we compared it and we didn't find any difference in outcome. Now this is for the radiation and medical oncologist. So I always see these patients who come frail and they can't walk around and nutrition is looking bad, and you send them to medical oncologist, advanced tumor for chemotherapy. They say, not fit for chemotherapy. You send to my radiation oncologist, send for surgery, not fit for radiation oncology. Then you send them, oh, it's MSI, hi, send them for immunotherapy. Say, no money, send them to surgeon. So you think, what do you think, this surgery is free? Not really. So, okay. So let's come to, this is a real situation, 68-year-old man, bleeding PR, multiple discharging sites. Someone had evaluated mucinous adenocarcinoma. I think the MRI pelvis for something like this. Ooh, is it working? Anyway, it's not opening there. So the disease is extending into the rectal space. It's multiple perineal sinuses. We did this biopsy at least 5 or 6 times in a month. So we think it will be too much for us to operate. So we sent to radiation oncologist. What do you think? No positive biopsy? Looks like a tumor now, definitely, man. You're the man, the God to save him now. Mucinous tumor is not going to respond. You gave radiation the last time, man. You have to give it now.
For mucinous, I guess even before me and Hirak were agreeing, radiation probably will not help that much. But and this is a bad disease.
No biopsy.
No biopsy, sir. For radoncs
Okay,
are
no,
very particular. We
no,
don't treat without biopsy, sir.
No. I operate without biopsy for right colon, man. You have to do it now. Someone has to take the risk sometime.
Yeah.
Look at man. The man has got a fistulating perineum. Tell me, it is not mucinous now. What do you think?
So, without biopsy, I'm not sure, sir. We have never treated without biopsy.
Okay, Viraj.
Still need a
No, biopsy, without biopsy, we don't do systemic treatment.
So finally, the only people who are taking risk is the surgeons. Okay, because I think we have to do the right thing. So I think we consulted them for a negative biopsy, and this was like a fistulating perineum. So we did a lap APR with a rectal fossa and obturator internus, turned him prone and cut the bone, and it went okay. So we are waiting for this. I think we did quite a few. Sometimes they can always come in bunch. I remember in a year we did 10 of these cases, that we have the largest series of fistula and APR, but it is there. Okay, next one. This is for the this one. 35-year-old female comes, bleeding PR, 2-4 centimeter from the anal verge, lesion is about 2 or 3 centimeters. He is less. Looks very resectable, 35-year-old. Pandey?
So first thing, this is mid rectum, sir, not lower rectum. This is mid rectum.
4 centimeter. 4 centimeter.
Yeah. So.
And when she comes into your shop and she says, "I don't want surgery," I said, "What the hell are you doing here?"
So.
No. Anyway, you tell your plan.
So
35-year-old.
She's T2 N0. That is the only problem is she is lower rectum. So prospect probably will not be. But one option I will give prospect. I'll give one option. I'll give to her.
T2 N0, man. So prospect, you want to think for surgery. Prospect was only surgery. You want to give chemo and then.
Sorry, opera, sir. Opera I'll offer.
Yeah, that's okay. So you want to give some neoadjuvant therapy to go for weight and watch.
Yes.
Praveen?
yes, sir, definitely.
But she's 35, I think.
So we need
maybe
to
she just got married last year.
Yeah, so the fertility issues need to be addressed.
And
Yeah, so we're in transposition, and the fertility issues, once it is solved, so that needs to be discussed. Probably an upfront surgery versus a non-surgical option with fertility issues. That is
Okay.
something they need to.
So difficult one. Young person comes to you, you have to think of their ovary, they have to think about their sex life also. You have to think of lot of things. And but if you think of ISR, then think. So you have to counsel, and patient makes the decision. What do you think, boss?
Is this a circumferential growth, sir?
3 centimeter eligible for local excision, but it's T2 of course. So
Because even at Tata for T1, T2 for non-circumferential up to 7 centimeter, they give brachy in these kind of patients.
oh my God,
Yeah.
that scares me, man. I know, it's very scary, man. I don't know which one, the radiation oncologist or the treatment. I'm just joking. You'll go and tell her. Correct. Bol Viraj, last one.
So organ preservation after fertility is being taken care of. Opera study where you do radiotherapy and then add brachy boost
Okay.
had almost 70-80% CR rates.
Yeah, I think a lot of things are coming up now. So, upfront versus neoadjuvant therapy. So, I would say intersphincter resection if he doesn't want surgery or large and is happy to accept chemoradiation, and she has to go for lap ovarian transposition, oocyte preservation. So, we know early tumor, if you give them complete response rate with OPERA, or not OPERA, with the other trials is almost more, we'll come to it. 50 to 60% will definitely be there, and now with the Star Trek trial, it can go up to 80%. So, for early rectal cancer, there are so many trials now. There are CARTS, there is TREC, there is GRECA2. All of them have radiation, and they used to do local excision. But then they realized they're doing a lot of local excisions, and the morbidity is higher. So instead of that, if you wait and watch for 12 weeks, half of them would go for wait and watch, and the rest you can do local excision. There is another trial by NEO also where you give chemo alone, and that also has an organ preservation rate of, okay, let me go on the next slide. So you can see the organ preservation rate giving radiation. So smaller the tumor, the greater the chance of organ preservation. For NEO, it was 60%, but long-term data is not available. For chemo for organ preservation, you can't do, but you can do all the other trials. But important thing is, once the patient doesn't respond, or when you do local excision, some of the time margin comes back as positive or this one. If you look at completion TME, when you ask them, the people who agree to redo surgery is very less. It can vary to 50 to 70%. So you have to select your patients well for this one. And most important thing, the results of the Star Trek trials are out. They compared chemo radiation versus short course, and with the long course chemo radiation, almost 80% can have organ preservation. Half of them will be because of wait and watch at 12 weeks, and by another 16 weeks they do local excision. So 80% can have organ preservation, so that is happening. So this is there. We won't go into lateral pelvic nodes. So Viraj, if someone comes to you with the same thing and it is MSI high, what would you do?
Easy. MSI high, easy.
So how long would you give the duration of therapy?
6 months immunotherapy.
If someone comes to you with colon and MSI high,
Colon,
yeah, not locally advanced.
what's the stage, clinical stage?
Okay, T2, N1 maybe. Okay, let's make it N2 and make it T3.
So then it's easy, right?
So how many cycles of
So
immuno would you give?
we do 1 cycle of CTLA and 2 cycles of immuno, and within 4 to 6 weeks you'll operate, and no chemotherapy ever again, and they'll be cured.
Okay, that's good. So
100%
we'll come back to it.
survival rate.
Right, I know, survival should, no, looking very good. Niche 2 trials are pretty good.
So then of course the question comes, do you need operation? Because that's the follow-up study.
That's right. I think that's going on now, isn't it, with the multi-thing recruiting. Okay, for Pandey and Praveen, this is a lady, locally advanced rectal cancer, had an obturator node. You gave them some sort of neoadjuvant therapy. We'll finish it. T2N0 and lateral pelvic node. Will you do upfront TME and lateral pelvic node dissection, or do you want to give chemo radiation? T2N0, primary resectable, you have a lateral pelvic node.
Chemo radiations.
Chemo radiation only, sir.
Okay, while you are a good surgeon, you can take the lateral node out.
But the recurrences are very high, sir.
You have not operated for a month now. Okay, so there is a data for everything. So Japanese used to do a lot of this, and T2N1 with lateral pelvic node, if you do upfront, everything is bad. Local recurrence is bad, overall survival is bad. So once you have lateral pelvic node, poor prognostic thing. So of all the organ, you can manage chemotherapy for everything. You cannot manage it for organ preservation, and you cannot manage it for lateral pelvic nodes. Lateral pelvic nodes always require chemoradiation. That's okay. And suppose if it was MSI stable, what do you think, Viraj? Can you give immunotherapy?
Yeah, so I was going to say that you know, in 4 to 5 years, I think so every rectal cancer patient will end up getting botensilimab and balstilimab.
So I think with the
And-
new Astro meeting, Stellar 2 trials have come out.
You know,
and it's looking
then we
very
will
good.
not be discussing all these trials.
Don't worry, I will be doing only talks. Spend my weekends making money out of this. A lot of people do that, motivation talks or speaker. So Stellar 2 is a trial. Well, if they say if you give chemotherapy or radiation, it changes the immune status of the tumor. So it makes it more sensitive to immunotherapy. So in this way, they compared short course and immunochemotherapy, and immuno-TNT had a complete response rate of almost 40% or so. So things are changing. And then you thought this was a Chinese trial. It's not very good. And there is a study from UK Prime RT where they compared. You thought short course is almost hard because Rapido has long recurrence, I think functional outcomes, but SCRT the only thing where the immune response come out. So in Prime RT they compared head to head SCRT with chemo radiation, and if you look at it, chemo radiation, short course radiation therapy works. So short course is still there with this Prime RT. Thank you very much. And there is of course a magic trial. So if nothing else works, even if the MSI is stable, give chemo and try immuno karke. So I'm going to change I'm going to take 1 year off and do a degree in immunology and make some money. Thank you everyone. It was a pleasure to be here and such a great team. Thanks Viraj for the invitation.
Thank you, sir. Thank you. One picture.